I'll hand over to Jo and Hannah.
Good afternoon, everybody. It's great to see so many people here. I'm just going to share our slide deck with you, so bear with me for a second. There we go. Can everybody see that? Is that okay?
Yeah.
Oh, there's someone out there. Brilliant. So I suppose we should start with some introductions. My name's Jo Sedgwick. I am an advanced practice lead. I work for adult social care at Westmoreland and Furness. And my colleague, oh, that was my first point. If it's all right for everybody, just make sure that their microphones are on mute. We do have quite a lot of people in the session today. There is the chat function, so if there's anything that you need to share, please do. As I was saying, I'm here co-presenting with my colleague Hannah as well. Hannah, do you want to introduce yourself?
Yeah, hi everyone. It's nice to see you all. My name's Hannah Johnson. I'm the named nurse for safeguarding adults at Morecambe Bay Hospitals.
It's Hannah. So we're just going to start off by thinking about what we want to get out of the session today. So hopefully everybody's in the right place. The session today is a lunch and learn session. We've got a maximum of an hour together, and we're going to be talking about the Safeguarding Adult Review for Poppy, which was recently published. So in terms of what we'd like people to get out of the session, hopefully today, we're going to be talking about Poppy, who sadly passed away in December 2022. Due to concerns about how agencies work together to protect Poppy, a Safeguarding Adult Review was instigated. So the aim of today's session, we really want people by the end of our hour together to feel that they're informed about who Poppy was and what she experienced. We want you to be aware of the findings of the Safeguarding Adult Review. We want you to feel supported to reflect on those findings and have a think about how it may impact your practice, and also confident to go back to your organisations and to talk about what those findings are and to talk around what changes you feel might be needed, if any. We are quite limited on time, as I said. We've got an hour, so if you could keep your microphones on mute, that would be great. We are recording the session today. You'll see the little record button has started at the top, so just to make people aware of that, and also that it will be available to look back on the SAR website once we've sorted that out. Please do use the chat box for any kind of ongoing issues. We may not have time to take questions. If we do, that's great. But if not, if you do have questions, if you put them into the chat, we will do our best to address them and get back to people, whether that be direction to resources or feedback or whatever that looks like. So I hope everybody's okay with that. My last point before we get going is just that some of this discussion can be triggering. I'm aware that some people may work directly with Poppy, so please just make sure that you're taking care of yourself and you do whatever you need to do. Okay. So we wanted to just pop a slide in first of all for those of you who may not be as familiar with the Safeguarding Adult Review process about what a Safeguarding Adult Review or a SAR actually is. So what we've popped on the slide here is the Care Act 2014 criteria for a Safeguarding Adult Review. So as you can see, the Care Act places a duty on safeguarding adult boards to arrange a SAR when the case involves an adult with care and support needs, where there is reasonable cause for concern about how the Safeguarding Adult Board or its members work together to safeguard the adult and the adult has died, or the adult is still alive, but the SAR knows or suspects they have experienced serious abuse or neglect, sustained potentially life-threatening injury, serious sexual abuse or serious impairment of health or development as a result of abuse or neglect. Very wordy, but if anybody wants to go and find it, I think it's section 44 in the Care Act. Just to share with you as well a little paragraph from the Care Act 2014 statutory guidance, which says that local safeguarding adults boards must arrange a safeguarding adult review when an adult in its area dies as a result of abuse or neglect, whether known or suspected, and there is a concern that partner agencies could have worked more effectively to protect the adult. Safeguarding Adults boards are free to arrange a safeguarding adult review in any other situations involving an adult in its area with needs for care and support. We've popped the link to both of those resources on the slide at the end, so if anybody does want to go and have a look at that criteria, it should be available for you there. Okay, I'm going to hand over to Hannah now just to give you a brief outline of Poppy's story.
Yeah, hi again everyone. So Poppy lived in Cumbria at the time of her death, and she had care and support needs, and there was a concern, as we've mentioned, about how agencies work together to protect her from self-neglect and mitigate the risks to her physical health by not administering her insulin. Poppy was born in Scotland, which is where her daughter still lives, and she'd moved to Cumbria when she was approximately 40 years old, with a husband who in later life had acted as her main carer. In the years leading up to Poppy's death, Poppy had cared for her dog, and after the death of her husband in 2020, had remained socially isolated, with very limited informal support in her local area. It was recorded that Poppy had adverse childhood experiences and had experienced trauma within her life, and that in adulthood she'd alleged domestic abuse and was a victim of fraud. Poppy suffered from a number of physical health conditions that included diabetes, fibromyalgia, and chronic fatigue syndrome. Her vision was poor and she had cataracts, which may have impacted on her ability to administer her insulin. Additionally, Poppy also had a diagnosis of depression and anxiety and had required a mental health inpatient stay in 2019. Poppy had involvement from multiple agencies, including adult social care, district nursing teams, mental health services, GP and diabetes specialist nurses. Sadly, Poppy died in December 2022, and subsequently a SAR referral was made, and Cumbria Safeguarding Adults Board were in agreement that were missed opportunities for agencies to work together to support Poppy. This lunch and learn session will briefly cover each of the key findings and considerations for professionals. And I'll pass you back to Jo.
Thanks very much, Hannah. So there was actually 6 key findings as a result of the SAR. So what myself and Hannah have tried to do is just break them down a little bit. The review posed kind of questions for each of those findings. So we've tried to include those, a little bit of key information, and then a takeaway point for each one as well. So I'll jump in with the first one. So finding 1 was in relation to partnership and multi-agency working. As Hannah mentioned, Poppy received support from health professionals in primary care and secondary care, including district nurses and diabetes nurse specialists to support with physical health conditions. She was also known to adult social care, had a package of care in place, and was referred to specialist mental health services. So one of the key questions here was, what can Poppy's experience of the system in Cumbria teach us about multi-agency working and information sharing? As you can see here, partnership working in the case of Poppy focused primarily on risks relating to health conditions. The SAR identified that partnership working can take place through formal or informal systems. There's no kind of set route for that. But what it did identify is that the case of Poppy demonstrates the difference between communication and partnership. So the evidence shows that communication within sectors, so between kind of adult social care professionals and between health professionals, was effective, but that intra-communication was not as effective as it should have been. So essentially communicating with external agencies. It was relying more on one-off communication, sharing of information, rather than kind of joint working and shared decision making that actually characterises partnership working. In the case of Poppy, partnership working took place through ad hoc multidisciplinary team meetings, which were convened as and when necessary. They did provide a forum for discussion, but maybe not that shared decision making that brought all those factors together in a way that was as effective as possible. So in terms of takeaway points, as organisations, as individuals, we need to consider how we're working in partnership, particularly with external partners, so partners from other sectors, to be as effective as possible for the individuals that we support. There was a direct recommendation as a result of the SAR that CSAR publish a guide to effective MDT working, and that's currently in development and will hopefully be available later in the year. So once that's there, we'll make sure that that gets out to people, and hopefully that will bring us together in terms of our working practices. So I'm just going to hand over to Hannah to talk you through the next finding.
So as you can see, finding 2 was around mental health and diabetes. And as I mentioned earlier in the presentation, Poppy did have some mental health needs and was also diagnosed with type 1 diabetes. So the questions posed to the SAR group were, what were professionals' views of the impact of Poppy's mental well-being on her ability to manage her physical health condition? And how effectively did professionals explore Poppy's mental health? So as you can see, the challenges faced by people with diabetes and experience of mental illness are complex, and they're often multifactorial. and they require an integrated approach and support and care from an effective multidisciplinary team. Yet often diabetes and mental health conditions are managed and treated separately. This can result in a silo approach to the treatment of mental health and physical health, or a tendency to focus on the one most pressing issue at that time. So some key points to make. So despite a number of agencies having an awareness of understanding of Poppy's circumstances, there were missed opportunities to consider how Poppy's physical health and mental health were coexisting and the impact that they had on each other. There were appropriate assessments of Poppy's mental health while she was an inpatient in hospital, and that's the acute services, prior to her being discharged, after Poppy informed staff that she'd stopped taking her insulin as a way of taking her own life. However, the outcome of these assessments were not always shared with the community team supporting Poppy, and there was little evidence of the impact of her physical health and mental health coexisting being considered. Poppy had a previous mental health admission in 2019 for the treatment of a non-organic psychotic disorder, following experiencing auditory hallucinations and paranoia, and these were said to be in relation to a long-standing fixation and paranoia with the neighbours. Within the SAR process, it was apparent that there had been continued concerns with very similar themes. However, all agencies had not been aware of this information. Had this information been readily available for practitioners, there may have been further considerations into the support in which Poppy requires. So the key finding and takeaway point from this one will be we need to consider how we work together with other agencies to address coexisting physical and mental health needs and share information appropriately to meet the needs of those that we support. And we've just added a link there around supporting people with their emotional health who also have a diagnosis of diabetes. And then on to finding 3, which was around treatment concordance and decision making. So the question posed to us for this one was, how do agencies address the issue of mental capacity, autonomy and freedom of choice? So the principles of the Mental Capacity Act are designed to protect individuals' rights to make decisions, even unwise decisions, and concordance is a term used to describe to the degree to which an individual follows a treatment plan. A number of factors influence concordance with diabetes treatment and those choices that can result in medical self-neglect. So in the case of Poppy, of greatest concern to professionals were the decisions that impacted on Poppy's diabetes. So they were the decisions involving medical treatment and insulin compliance, lifestyle and diet. Where capacity was considered, it was in relation to Poppy's ability to consent to treatment and follow diabetes self-management plans, including the self-administration of her insulin injections. Professionals all felt satisfied that Poppy was able to make decisions for herself in relation to the management of her diabetes. A previous safeguarding adult review in Cumbria noted that there are many reasons that individuals make unwise choices or decisions, but that people rarely choose to neglect themselves, such that self-neglect is a consequence, not the decision to be made. And concordance is a term used to describe the degree to which an individual follows the treatment plan. A number of factors influence concordance with diabetes treatment and choices that can result in medical self-neglect. There are many different factors which are considered to influence this concordance, and some of these are trust, such as relationships with professionals and an acceptance of their views, difference in understanding and believing in risks and severity of that. Capability, so as we mentioned earlier, we're not sure that Poppy had the ability to be able to administer her own insulin. And self-perception, lots of people with diabetes don't feel unwell and they're used to living in that way. So the takeaway point from this one is, how can practitioners explore individuals' decision making and the factors surrounding unwise choices? And then moving on to the final finding from me. So this was around interconnected risk. So the question for this one was, how do agencies assess risk and what was the professional understanding of the risk facing Poppy? Did this, or how did this differ from Poppy's own views? So as we know, many of us are practitioners on the call, we might often need to assess multiple risks related to medical, psychological and social factors, and risks may often be interrelated and complex, and actions taken to address one risk may have an unintended consequences in another. A multi-agency approach, where it might not always be indicated, could have supported with the assessment of the interconnectedness of the risks in different areas, joined up different areas of risk and improved the information available. In the analysis, which is within the learning brief, the probabilities and likelihoods gives us more information and expertise to give us greater accuracy, better risk analysis and more effective risk management. So in the case of Poppy, risk assessments were carried out by various agencies involved in a carer who had contact with Poppy in different settings. And the categories of risk were analysed by agencies, which included risk to self, risk of self-neglect, and the risks of non-concordance with treatment, risk from others, and risk to others. However, these risk assessments were completed in silo and they weren't joined up and developed as multi-agency risk assessments. With the benefit of hindsight, it's possible to see how actions taken to address one of the risks may have had unintended consequences to another. So an example of this is that in an attempt to minimise the distress caused to Poppy on a daily home visits for her insulin administration and the associated risk of the verbal abuse towards staff, a plan was put in place that in order for a home visit to take place, Poppy would have to proactively contact the team who were administering that insulin to give her consent and confirm that she was happy for a practitioner to visit. Although this plan reduced the risk of the home visit distress and the verbal abuse towards staff, the unintended, however, may have been predictable consequence was that there was a reduction in contact with professionals, an increase in disengagement and a worsening of non-concordance with insulin. A multi-agency approach may have supported the assessment of the interconnectedness of the risks in different areas and joined up those, and would have improved the information available to practitioners. So the takeaway from this one is just that risk should not be assessed in silo and should be carried out in a multi-agency forum, such as a safeguarding strategy meeting.
Thanks very much, Hannah. So I'm just going to pick up at finding number 5, which is focused on self-neglect. So the question posed by the Safeguarding Adult Review was, how do agencies in Cumbria interpret the definition of self-neglect? What sort of behaviours are included or excluded? And how did this interpretation of self-neglect impact on decisions made in this case? So just to pick up first of all in terms of definitions of self-neglect, there is a definition contained in the Department of Health, Care and Support statutory guidance for the Care Act, and it defines self-neglect as encompassing a wide range of behaviour, including neglecting to care for one's personal hygiene, health or surroundings, and includes behaviours such as hoarding. Research has added to that description in terms of 3 recognisable forms of self-neglect, which include lack of self-care, lack of care of one's environment, and refusal of services that could alleviate these issues. So as you can see, guidance suggests that in circumstance, so Poppy's case would have fallen within that definition of self-neglect in statutory and local guidance. And guidance suggests that in such circumstances, incidents must be reported to designated safeguarding leads, and that safeguarding adults procedures should be initiated to manage risks. In terms of Poppy's case, the safeguarding procedures proposed by the CSAB self-neglect guidance, which include the points above, were not actually triggered until relatively late on in the case. So Poppy sadly died before multi-agency safeguarding procedures could begin. I think it's only fair to say there is no certainty that multi-agency safeguarding procedures would have been able to change the outcome in this case. However, safeguarding procedures may have helped to reduce the risk of harm resulting from self-neglect. The takeaway point for this one is that cases of high-risk self-neglect should be referred to safeguarding under the self-neglect guidance at the earliest opportunity. There was a recommendation also that the Safeguarding Adult Board may need to look at relaunching or raising the profile of the self-neglect guidance in relation to neglected health conditions. The slide just has an active link at the bottom of it, which takes you directly to the Safeguarding Self-Neglect Guidance. It's also on the resource slide, which we'll have a look at the end of the presentation. We'd also just like to share at this juncture as well a video. So this is available on the Cumbria Safeguarding Adults Board website. Hopefully I have got the sound settings on my computer right, so that when I play it, you can all be able to hear it. I am on a second screen at the moment and it makes my sound go a little bit funny. So bear with me for a second. I'm just going to unplug that. And then I'm going to play the video.
Everyone is different, and we're free to make our own choices about how we live and what is healthy for us. But sometimes a traumatic event, lots of stress, or an illness or disability that may get worse over time can make living our lives more difficult to manage. Like mess in a room, self-neglect can build up slowly, so it's hard to pinpoint exactly when it becomes a worry. Shame also builds up and can make it harder for people to ask for help. Here are a few things that you can look for in yourself or someone you know that are signs that things have started to get out of control. Have any important appointments or medications been missed? Has there been a change in their usual appearance? Has there been a noticeable change in mood or usual routines, like not wanting to go out or see people? Is there enough food in the house to make a meal? Or is the fridge empty or full of food that's gone off? Have alcohol and drugs, or even the amount of time spent online, become more of an issue recently? Some people who self-neglect will try to build self-esteem by looking after things or even animals. Perhaps the home is now so full of things and/or animals that they don't want people to see how they live, or it's become difficult or even dangerous to live in. Does the house need major repairs? There may be times when someone loses their ability or mental capacity to make their own decisions, or is unable to take steps to protect themselves, but there is a wide range of support available. If you are worried about yourself or someone else, we know it may be difficult to do, but it's important to reach out and ask for help and advice as early as possible, even if you don't think they are currently ready to accept help. When you reach out, you will be listened to, and we will work with you at your own pace, based on what you want to happen. So please, don't wait. Get in contact today.
Okay, just bear with me while I get my screen sorted out. Okay, I'm just going to stop sharing just for 1 second, just reset it. That should just be coming back on your screens now. Can everybody see that okay?
Yeah. Yeah.
Brilliant. Okay, so on to finding number 6 then. So number 6 was around professional curiosity and challenge. The question that was posed by the Safeguarding Adult Review was, how do agencies in Cumbria apply the principle of professional curiosity in safeguarding practice? So the definition that we've got here on the slide of professional curiosity is the capacity and communication skill to explore and understand what is happening within a family or with an individual, rather than making assumptions or accepting things at face value. So in terms of key information, throughout the chronology with regard to Poppy's case, professionals record high levels of defensiveness, also reluctance to engage and avoidance. Examples of this included being verbally abusive to staff and demanding visiting professionals leave her home. Poppy would often go away on holiday without letting practitioners know where she was going, or arranging for insulin supplies while she was away. Say agencies responded differently to the tension in Poppy's case, including making safeguarding plans requiring Poppy to proactively contact the team in order to access a visit. The SAR report identified that this is a really challenging area, and that often identifying issues of professional curiosity requires a degree of hindsight. Therefore, effective learning about professional curiosity, we should be doing this in quite a sensitive way. Developing professional curiosity is a matter of nurturing a desire amongst practitioners to know or learn something about what's happening in an individual's life and taking action when evidence of abuse, neglect, or self-neglect is found. There can be significant barriers to professional curiosity, and there is guidance. I've popped the link at the bottom to support people to consider these, but just to share a few with you at the moment. So examples of barriers that people might come across in regard to professional curiosity can be accumulating risk. So that's where professionals can deal with risk and incidents in isolation, but we're maybe missing the bigger picture in terms of what's happening. Confirmation bias, so we go in as professionals looking for evidence that supports ideas that we might already have about that person. The rule of optimism, so rationalising new or escalating risks even though there may be evidence to the contrary. Disguised compliance. Uncertainty, so those kind of unsubstantiated claims, retracted disclosures, contested accounts, that type of thing. And also managing tensions, which was probably the case here. So disagreement, defensive disruption, aggression. Sometimes it can deter or mask what the real issues are for people. The result of those barriers and the challenges of professional curiosity mean that practitioners need good support, they need training and reflective supervision so that we as a group, as organisations and individuals, we can try to overcome some of those barriers. So as an organisation and as individuals, we can look to implement the cross-board professional curiosity guidance for practitioners, which has been published by SAR. As I said, the active link is at the bottom. It's also on the resources at the end. Paying particular attention to actions that organisations can take to support professional curiosity. So they were the 6 key findings from the SAR report. We wanted to kind of try and bring things together a little bit towards the end of the presentation. I suppose the real question is, so we've had all this, we've looked at all the findings, but what next? What do we do after we've looked at these? These are some of the suggestions that Hannah and I discussed. So go back to your organisations and talk about the information that we've shared today, talk about the recommendations and the findings as a result of Poppy's case. Have a think about what you might do differently. Is there anything going forward based on this learning that you might change? It might be that you identify areas of really, really positive practice, and that's a really good thing. So part of it is making sure we're sharing that and we're building on it with our partner agencies as well. Talk about how to have difficult conversations and how to apply professional curiosity, what that might look like in practice, the kind of actions, the kind of things we might want to consider when we're applying that. And that can be done in peer support, it can be done in supervision, it can be done in groups, personal reflection, whatever works best for you. Any learning that you do take away from these, be confident about sharing that within your organisation. Check your organisational policies, especially in the relevant learning areas that we've identified today, but also look for maybe external sources. As we've said, SAR publish a number of supporting policies and pieces of guidance that you might want to bring into the organisation and consider. Focus on MDT working to support that positive risk management and keep the conversation going. Maybe consider having key learning outcomes as a running agenda item on team meetings and/or supervisions. And if in doubt, as a practitioner, as an organisation, seek support, ask the questions, because hopefully those are the things that are going to prevent these kinds of incidents from occurring again. So as I've said a number of times, there is a resources section just on the end of the presentation. Hopefully that has links to all of the documents and policy and practice guidance that we've talked about within the session today. If there is anything missing, please let us know. You may have questions about other pieces of guidance that may be helpful. Said the chat box is there, or you can contact, I'm sure, Simone or Helen to make those requests. But that's everything from us today. So I hope it's been helpful. I hope it's giving you some insight and some pieces of actions, some things to think about. I'm just going to hand over to Simone and Helen now, if that's all right with you guys.